The patient is 35-year-old male, resident of Pudupet, Pondicherry, hospital attended by occupation, informant patient himself, presented to us with the chief complaints of weakness of both the lower limbs since 8 years and loss of sensation in both the lower limbs since 8 years, difficulty in passing urine and stools since 8 years. History of presenting illness. Patient was apparently normal until August 2015 when he suffered a road traffic accident while riding a two-wheeler. He was hit from behind by a car, after which he fell on his back on the bonnet of the car, following which he fell on the ground and had loss of consciousness for approximately 5 minutes. He was woken up by the people nearby. Then he complained severe sudden back pain, which was localized, non-radiating, and aggravated when he tried to move. After that, when he tried getting up, he was completely unable to get up and completely unable to use both the lower limbs. People nearby him lifted him up. He was unable to stand even with support and fell down immediately. He noticed that his limbs were loose and flail after the trauma. And he was also not able to feel the sensation of his clothes initially below the knee. But he was alert and was able to respond to the people around him appropriately. He was taken to a hospital nearby in a car in sitting position because he was not stabilized while traveling to the hospital by a spine board. After reaching the hospital, he complained that he was not able to feel the sensation of his clothes below the hip. He underwent a spinal surgery the very next day. And post-surgery, the weakness of the both lower limbs has remained the same, without worsening and improving. Both the limbs were affected simultaneously and symmetrically, with both the proximal and distal weakness. Since that incident, he is unable to use both the lower limbs. The lower limbs were loose and there was no stiffness or heaviness of the limbs at any time. And he noticed that he was unable to feel the clothes and bed sheet from below umbilicus post-trauma and not able to perceive pain, hot and cold sensations below umbilicus. And he also gave history of band-like sensation just below the umbilicus. And the lower back pain was continued post-surgery, but the intensity of the back pain was reduced. The pain was more in the lying down posture, but not radiating, and the pain was reduced in sitting posture when compared to lying down posture, which was relieved only after heavy medications. Patient was catheterized during spinal surgery. 4 days later, when urinary catheter was clamped, he was not able to appreciate the bladder fullness. When the catheter was removed, he was unable to appreciate bladder sensation or unable to initiate the micturition. After a few hours of removing the catheter, he noticed urine dribbling constantly in small amounts and suprapubic fullness was present. He was catheterized again and almost 2 liters of urine was drained. Patient didn't pass the stools for 4 days post-surgery. Initially, suppositories were given, but they were not useful. He was unable to initiate defecation. Manual evacuation of the stools was done. Presently, patient himself catheterizing on his own 3 times a day in a periodical manner or whenever he sees dribbling through the urethra and performing manual evacuation of stools daily. History of erectile dysfunction is present since the traumatic event. He noticed there was decreased sweating present in both the lower limbs and limbs were dry always. For the subsequent years, he noticed that thinning in both lower limbs was present, but it was not associated with any twitching of the muscles. There is no history of weakness in upper limbs and able to do all his daily activities with the upper limbs and able to lift his neck from the pillow, able to roll over the bed and get up from the bed. No history of difficulty in breathing or twitching of the muscles. He was able to feel the clothes, hot and cold sensation above the umbilicus. There is no unsteadiness on closing his eyes or washing his face in sitting position. No electric shock-like sensation down the spine while flexing or extending his neck. There was no history of decreased sense of smell or visual disturbances or double vision, drooping of eyelids, difficulty in appreciating hot and cold water while washing his face, no asymmetry of the face, and there is no history of inability to close eyes or diminished taste sensation. There is no loss of hearing, tinnitus, vertigo, difficulty in swallowing, nasal regurgitation, nasal twang of voice, and difficulty in lifting arms above his head or turning his head. No spillage of food while eating, nor clumsiness of hand. No history of giddiness or palpitations. No history of neck stiffness, fever, headache, seizures, or photophobia prior to the episode. No history of loss of weight, recent vaccination, or exposure to pesticides, chemicals, or heavy metals. Past history, not a known diabetic or hypertensive or asthmatic epilepsy or TB. Personal history, mixed diet, smokes 1 cigarette per day for 5 years before the trauma, and use it to drink 180 ml of brandy every day for 5 years before the trauma. And after trauma, everything he stopped. Married and has 2 children. Family history, born out of a non-consanguineous marriage. Birth history and developmental history not known. Summarizing the history, he is a 35-year-old male with no previous comorbidities, presented with acute onset bilateral symmetrical flaccid weakness of both the lower limbs since the day of trauma, which happened 8 years ago, which is static and associated with wasting for subsequent years. There is pansensory loss of touch, pain, temperature, and vibration sensations below umbilicus, associated with band-like sensation just below the umbilicus, with a significant autonomic involvement of bowel and bladder dysfunction, without involvement of cranial nerves, higher mental functions, and cerebellum. Probably the lesion is in lower spinal cord with a definite sensory level, and also there are features suggesting conus and cauda equina syndromes, probably secondary to trauma. So my differential diagnosis is traumatic myeloradiculopathy with a cauda equina syndrome, or ischemic myeloradiculopathy due to injury of artery to Ardham cavus, and a vertebral fracture dislocation at multiple levels, or herniation of the disc.
Okay, we'll start with that first symptom.
Yes, ma'am.
Following the accident, this patient became unconscious, no?
Yes, ma'am.
So, what could have caused that unconsciousness?
Any concussion injury, ma'am? Any concussion?
So, unconsciousness in an accident could be due to several reasons, no?
Yes, yes, ma'am.
So, what are all the points? You said one concussion may be possible.
Yes, and concussion.
What other causes? Agreed condition, concussion, yes.
Yes, ma'am. And he has, maybe he must have direct brain injury causing a subarachnoid hemorrhage, or he must have been having these injuries, ma'am.
Okay, so a head injury which causes the loss of consciousness,
yes, ma'am,
can be categorized into 2.
Yes,
one is because a spine injury cannot produce loss of consciousness, obviously.
Yes, ma'am.
That he noticed only later. Soon after the accident, what he noticed was that he was unconscious.
Yes, ma'am.
And later he came back into consciousness. So that part is the first symptom of this patient.
Yes, ma'am.
Spinal cord is the sequelae. So, and obviously we know that spinal cord cannot produce unconsciousness.
Yes, ma'am.
The head injuries are categorized into 2. One is dynamic injuries, 2 penetrating injuries.
Okay, ma'am.
You can have a dynamic head injury or you can have a
Penetrating
head injury. And any head injury, if they come to your casualty, we ask certain questions to know whether there was significance in that injury or not. One is loss of consciousness, seizures, focal neurological deficit, bleeding from the ear, bleeding from the nose, loss of smell, or watery discharge from the ear or nose. That is CS of autoria, rhinorrhea. That will indicate that arachnoid or the dura has ruptured, and bleeding from the ear will indicate middle cranial fossa injury. Bleeding from the nose will indicate anterior cranial fossa injury. Focal neurological deficit will indicate focal injury, and loss of consciousness indicate global injury. So if you have a global injury on top of a focal injury, following the loss of consciousness, patient will be left with a focal injury with reference to the brain. Whereas in your patient, he did not have any of the other things which we talked about. He only had loss of consciousness, and which was followed by immediate returning to normality. So immediate returning to normality without focal deficit, but remaining stuporous, may have some seizures, will happen in diffuse axonal injury. As we said, in case there is a significant concussion without any condition.
Yes,
Condition or hematomas or subarachnoid will leave significant sequelae immediately. So it is not condition. It is not intraparenchymal hematoma. It is not subarachnoid hemorrhage. So can it be a concussion with a diffuse axonal injury? In that case, patient would have been in prolonged period of stupor with or without seizures. So nothing, because there it have micro bleeds. So in concussion and axonal injury, you get multiple micro bleeds. So they will have sequelae, but surgical things will not be there. But nothing happened, but patient woke up immediately. So what could have caused unconsciousness? It is a dynamic injury. You see, he was hit against two speeding vehicles. One is his scooter, another is the car. And his body came into a sudden stop. So it's an acceleration, deceleration injury, otherwise called dynamic head injury. So what this patient suffered is a dynamic head injury that produced loss of consciousness due to the acceleration, deceleration effect. He did not suffer from concussion, he did not suffer contusion, he did not suffer any axonal injury. Penetrating injuries do not produce loss of consciousness, like steering of the car or something getting broken and hitting in his head. They will produce focal neurological distress. They can produce seizures. Patient may be hemiplegic, patient may have seizures, but they do not get a transient loss of consciousness. If the injury is in the areas where seizures do not occur, they will have corresponding motor sensory cerebellar weakness, but they will not have loss of consciousness. So brief loss of consciousness with immediate return to consciousness without any sequelae indicate patient suffered a acceleration, deceleration injury because of the two vehicles were in motion and the body came into standstill. So that is what the patient suffered in the brain. This can sometimes produce loss of smell because these multiple olfactory nerves across the cribriform plate can be broken. So you can ask him whether his sense of smell became reduced. That may be the only sequelae. So that was the injury to the brain. Next, when he woke up, he found that he was paralyzed. Very straightforward.
Yes, ma'am.
So if he is paralyzed, many things you will consider. It could be a vertebral fracture with compression.
Yes, ma'am.
Or it could, so it could be a vertebral fracture which dislocated and compressed the spinal cord. So that is the best thing you can have. Spinal cord is compressed, but it is not neurotomized. So you decompress, patient will improve. Second, it could be a cord hematoma. So there can be a hematoma in the spinal cord. Still the patient, you may do the decompression of the cord hematoma and patient will be left with sequelae, but he will improve relatively better. Third is the neurotomesis of the cord, where the cord cuts into two. Sometimes it is a combination of vertebral fracture plus cord cut into two. And last cause is neuropraxic injury to the spinal cord. All these situations in the acute phase, patients will be paralyzed. So if it is vertebral fracture, you will find all the some of the features like gibbous, deformity of the spine, local tenderness over the spine, and then you do an imaging, you find that the cord is intact, then operate as early as possible, patient will have a near normal recovery. This patient was operated, you said that he was not mobilized in the recommended way of rolling over with 4 people, 2 people at the foot side and 2 people at the head side, and just rolling over without moving the vertebra. That is to prevent cord injury, but already this patient had cord injury.
Okay.
He was already paralyzed. Still, it is worth because it was not a neurotomesis and it was only a compression. It is important that you don't produce more displacement of the compressed vertebra. So it is relevant. So that part was a small deficit in transportation, agreed. But yes, did anybody find any gibbous deformity? We do not know.
Yes.
So what he was operated, was it on the vertebra, was it on the cord, we do not know. That information is not there for us now.
Yes.
If the patient had only compression, he might not have been left with this much sequelae.
Yes.
So therefore, if he had suffered neuropraxic injury, there the patient will be paraplegic. He can have bladder and other things, but vertebra will be normal. So he will not be operated. There we will have to give methylprednisolone, intravenous methylprednisolone. That is to prevent cord edema and prevent the ischemic penumbra from spreading inside the spinal cord and causing more necrosis of the cord. So very unlikely that it was a neuropraxic injury because somebody operated on him. So most probably he had a vertebral fracture and he might have had a compression which was causing a neurotomesis of the cord, or cord suffered severe necrosis at the site of injury, so that even after early decompression, fairly early decompression has been done, he did not recover. He might have had a combined injury of the vertebra plus cord. Most probably it must have been like that. The vertebra must have been repaired and the cord would not have recovered. So it is definitely not neuropraxia. Whether it is a cord hematoma or neurotomesis with a vertebral injury is a question mark for that point of time.
Yes, ma'am.
Now this patient is at this point of your C. So you said that immediately he was fully weak. And so that phase of spinal cord injury, when somebody is completely paralyzed due to whatever insult, what do you call that? What do we call that phase?
Acute traumatic paralysis.
It is called spinal shock.
Shock. Yes, ma'am. Okay.
So let us imagine. So I am coming step by step from the stage of injury. In case we had been there and we are looking after the patient and he is fully flaccidly paralyzed. So we think that it could be a spinal shock.
Yes,
so what are why spinal shock happens?
It is spinal shock. It happens because it is sudden withdrawal of the corticospinal tract input to the spinal cord, ma'am. Once the corticospinal tract input is gone, then the spinal cord doesn't know what to do. Like it will go into a shock stage, and it has
suddenly spinal cord is more a vegetative tract in human beings. It is only a transmitting wire, but it is given the job of managing the limbs. So suddenly it is not getting orders and it has to produce orders. So even in a partial cord injury or even in a neurotomesis, even in a neuropraxic injury, immediately after a spinal cord injury, patient may have complete loss of sensation, complete paralysis, and usually the acute shock bladder is neither capable of storing nor capable of emptying.
Small dribbling bladder.
So it will be a dribbling bladder.
Yes.
After that, depending on the tracts which are not damaged, there is a stage of recovery. So usually the first thing to recover is the sensation.
Okay.
So after the shock comes out, shock is more if the lesion is away from the brain. As the lesion is closer to the brain, the shock period will be less. And if the lesion is away from the brain, the shock will be more, duration of shock. Second, the shock will be more if there is additional infections or systemic problems like uncontrolled diabetes, or patient has got a bed sore, or multiple abrasions and skin injuries also occurred in the accident. So if there is an infection, or if the lesion is away from the spinal cord, or if there are serious comorbidities, duration of shock will be more. And the shock is very much less in lower animals, because lower animals, part of the spinal function is still active, like the various writing reflexes. I am sure you might have seen the cat going through a small hole in the wall, manipulating itself, bending. All these are taking place by writing reflexes, long loop reflexes. It doesn't use the command. Cognitive command and judgment is not much used. A cat wants to cross over to the opposite wall, compound. It doesn't want to think whether that house belongs to its owner or whether that house belongs to some dog is waiting there. All those things it doesn't think. It will see a hole, it will imagine that a rat is there, it can go and catch. So that's all, it's an impulsive decision. So spinal cord is still active in those animals. Using writing reflexes, it will go there. But human beings will think, can I go to that house? If I go there, will I be welcomed there? Or somebody will throw me out. So cognitive function is very much important in human motor behavior, whereas in animals it is less. So lower species have a shorter shock. They are still functioning. Higher the species, shock will be more. Far the distance from the brain, shock will be more. Additional soft tissue injuries, shock will be more. And complicating comorbidity, shock will be more. In this patient, none of those parameters were there, but he remained paralyzed. First thing to recover is sensation. Second thing to recover is the sphincter. So soon after shock, patient sensations will come within 24 hours. And that is due to whatever sensory loss remains at the end of 24 hours if there are no other comorbidities which we thought about. That is part of the injury. So next thing is the sphincter. So the dribbling bladder will go into retention.
Retention bladder.
Sphincters recover first. Third is the reflex.
Knee jerk will come first.
Earlier than the ankle jerk.
Ankle jerk.
And next you will have the tone. And last is the power. So that is the order of recovery. But in your patient, what happened? He remained like that.
Yes, ma'am.
So the reason for his complete paralysis at that soon after the injury and even after the surgery is not due to shock. So at that point, we can ask a question, was he so paralyzed due to shock? In that case, some hope is there. So he will come out of the shock and recover. So if you are examining the patient at that point of time, that is the question. So you'll say, okay, sir, we will wait. MRI is not showing any neurotoxicity of the cord. We have decompressed enough. It is probably shock. You may have a good prognosis.
Yes,
but you wait and look for these parameters, and he does not recover in this fashion in which he is expected to recover, except his alcoholism. He is not having any major comorbidity, so he is not recovering. That means his paralysis remained like that, not due to shock. There had been primary cord injury. So that is why he did not recover. So after the first two symptoms, we understand that our patient had a dynamic injury to the brain, because of which shearing stress happened. He lost consciousness. He regained without any sequelae. That means there was no axonal injury, no contusion, no hematoma, no penetrating injury to the brain. So that is with reference to the brain. He lost consciousness, so you have to discuss that point. Next, he had a paraplegia. Probably he had a vertebral dislocation, but he had an additional complete cord lesion. It was not a partial cord lesion with shock. So he had a fracture with complete cord lesion. Because of that, in spite of decompression, patient remained paralyzed. So that is the diagnosis at that point in the third or fourth post-operative day of your patient. Then you said that he had total loss of sensation. So was it involving pain, temperature, and posterior column sensations also? All sensations.
Yes, ma'am.
So, so what are the points we discussed at that at this point is?
Yes, ma'am.
Just for, I am sure you might have heard before, if it is just compression, it will be posterior column and pyramidal tract.
Yes.
They are pressure sensitive tracts. So compression will damage, maximum damage to posterior column and pyramidal tract, and mild damage to the autonomic and the other sensation.
Yes.
So it is not purely due to compression. So it is not purely due to, because he lost all modalities of sensation. So probably he had a neurotoxicity, most likely. It's a pan cord. Apparently it is a pan cord. All the tracts, irrespective of their special sensitivity to pressure. If it is a compression related pressure sensitive damage to the cord, it must have been more damage to the posterior column and corticospinal tract, and relatively better spinothalamic and autonomic. Everything was damaged together. So it is not just the pressure-induced cord damage, but the cord was independently affected in the process.
Ma'am, one small doubt, ma'am. Ma'am, in this patient, post-trauma, first he has below knee, ma'am, sensory loss. After going to hospital, after 2 hours, he's telling below hip. And after post-surgery, he's telling loss of sensation below umbilicus. Like, how come we can explain this, ma'am, that graded sensory loss?
No, his pathology must have been at the highest level he is experiencing now.
Yes, ma'am.
So how to believe that knee, hip and all, we don't know.
Okay, ma'am.
Because there is nothing like that. And once there is a cord injury can worsen like the ischemic penumbra in strokes. Like ischemic, once an infarct happens, after the infarct, free radical and biogenic amines are released, they expand the ischemic infarct. Like that, your traumatic cord injury can produce an expansion based on if there is a neuropraxic injury, cord injury can expand. That is why the role of steroids. But he definitely did not suffer from neuropraxia. It's a complete cord lesion. Below knee, below hip and all, you see, he was so sick at that time. So when we ask questions, he may imagine something and say. So it is very unlikely. I don't think it is possible at all. Or if it was a neuropraxic injury, immediately there can be some worsening and there will be good response after some time, with or without steroid. With steroids, the improvement will be very good. Even without steroid, if the cord was not completely transected, we expect him to spontaneously improve at least partially. That did not happen, instead he deteriorated. So I don't think that knee and hip, I will consider that as a soft symptom based on whatever information patient gives, and nobody has documented that. Did anybody document that sensation was below knee at that time?
No. It's patient reports only, ma'am.
Very unlikely, because he did not have a peripheral neuropathy. So symmetrical below knee will happen in peripheral neuropathy only.
Yes.
Or if it is a cord injury, what is the area below knee? It is L4, L5,
L4, L5,
S1. So if only those roots were cut, L4, L5, S1 roots were cut, he will have sensory loss below the knee and he will have a flaccid weakness of both legs. At that level, he can have a bladder because sacral roots are there. And at that time, you are expecting that a lesion below L3 will not spare the perianal.
Yes, ma'am.
So he cannot have a circumferential below knee sensory loss in a root injury. It will, and posteriorly, it will be little more longer and it will go up to the perianal region. So that is expected. If it is hip, it will be L1, below L1.
Yes,
all should go below L1. So from below L3, you are not expecting it to ascend to L1 and then to D6. It does not happen at all. Below L2, below L3 to perianal area, agreed.
And expect. Yes, ma'am.
But that is not telling. He got a circumferential below knee sensory impairment, which is only a completion phenomena by the patient's thought process. I feel so. And he might have imagined somebody did harm to him because many patients are suspecting hospitals and doctors. So I would have thought that doctors caused him damage. I don't know. I think like that. It's not possible at all.
Sure.
What is Kada-Ikiona at this point?
Yes, ma'am. Roots below L3.
No.
Roots below L3 is Kada-Ikiona. It is usually asymmetric reflex atrophic paralysis, ma'am. Usually,
but that is not in a trauma.
Yes, ma'am.
If it is a Kada-Ikiona trauma,
bilaterally
injury, it will be below L3.
Yes,
if it is a Kada-Ikiona syndrome due to a spinal canal stenosis or a neurofibroma or a lipoma, then it is asymmetrical atrophic reflexive. Whereas a traumatic lesion will be symmetrical below L3, roots below L3. What is conus?
Conus is S2, S3, S4, I mean S3, S4, S5 and coccyx, ma'am, conus.
Which one?
S3, S4, S5 and coccyx, conus.
Okay, what more point you have to tell here?
Ma'am, in conus, actually, in this case, if we see, if it's only conus involvement, motor deficit.
No, not this case.
Yes,
this case, we don't know. We are discussing a false history. I don't believe that history are below knee at all.
Okay, ma'am.
I'm just asking you theory question. So if
Yes.
you are asked what is conus, you should say it is segment below S1.
S1. Okay.
Whereas cauda is root, element, purely element. Roots below L3 is cauda iconic. Element, purely element. Cauda iconic is roots below L3. Conus is UMN. It is segments below S1. Epiconus is segments between L3 to S1. The segment between L3 to S1 is called epiconus, and segments below S1, that is the completion. What I asked is to tell it is segments, it is not roots.
Roots. S1.
So we typically tell a conus patient as a, because it is S1 to 3 perianal regions alone. So he will be ambulant. The epiconus part is normal. Only the conus is damaged, unlike the cauda. So patient will be ambulant.
Walking and
He will have bladder, bowel, and sexual dysfunction, very severe.
yes.
So these patients are described as
Walking,
leaking patient, but you can not tell it to the patient because it is considered for insult. So you can discuss it in among students for ease of understanding that epiconus is all right, so they will walk. It is only the bladder, bowel, and the sexual dysfunction. So they are described as walking, leaking patients. It is UMN. Because it is UMN, you might find that the sphincter reflexes are preserved. Angle jerk or some upgoing plantar may be there. And there is symmetrical perianal sensory loss. Whereas chronic cauda is asymmetrical, areflexic, and late bladder, and the late bladder will be element. So this patient that below knee and all we need not discuss because it is 8 years ago. He might have just imagined like that. It might not have been like that. And when you had a severe spine injury and severe agonizing pain, you only told that he had to be heavily sedated to relieve his pain. In that situation, I am sure nobody will be able to see how much sensory impairment was there. When there is severe pain and paralysis, his judgment is very unlikely to be correct.
Sure. Yes, ma'am.
So here we can say, we thought it is a pan-cord syndrome. So we can, for your exam purpose, you can tell me, name some of the ascending tracts in the spinal cord.
Ma'am, ascending tracts.
To ask one question only.
Yes,
these are common questions in MD exams.
Yes, ma'am.
So just want to know.
Yes, ma'am. Ascending tracts in the posterior column, ma'am, nucleus facialis and nucleus gracilis, and laterally lateral spinothalamic tract and ventral and dorsal spinocerebellar tracts, anteriorly anterior spinothalamic tracts and spino-olivary tracts, ma'am. And descending tracts are anteriorly
spinothalamic tract, you told her.
Yes, ma'am. Anterior spinothalamic tract and spino-olivary tract, ma'am.
And spinocerebellar, yes.
Yes, ma'am.
Cerebellar, we told. Okay.
Oh, yes, ma'am. Descending tracts are anteriorly anterior corticospinal tract and laterally lateral corticospinal tract is there, ma'am. Along with that, extrapyramidal tracts are there. Anteriorly vestibulospinal, tectospinal and reticulospinal tracts will descend, ma'am. Laterally rubrospinal tract along with the lateral corticospinal tract will descend.
Very good. And there are minor ascending tracts like spinotectal,
yes, ma'am.
Spinoreticular, spino-olivary. So the spinovestibular, yes, they are less prominent tracts, but they are also ascending. So to the medulla, ascending tracts are there. To the pons, so you can take each organ, spinovestibular, spinoreticular, spino-olivary, spinotectal. Similarly, tectospinal, all those things that you told, vestibulospinal, reticulospinal, tectospinal, you told, same kind of ascending tracts are also there. So good. So what is this? So we discussed about shock bladder. What is paraplegia and pan-cord syndrome? You can have a paraplegia flexion, you can have a paraplegia extension, and you can have a flaccid paraplegia. So when do you get a good ma? You are presenting very well, nice. So what are the features of when do you get a paraplegia in flexion?
Paraplegia in flexion it involves both the pyramidal and extrapyramidal tracts, ma'am. Actually, it indicates that the lesion is in the spinal cord. If the patient will have flexor spasms, will be there, and You only told, ma'am, actually, there is a short reflex afference in case of a neonatal life, which was replaced by a long reflex afference in case of adults, which maintain the extension attitude in case of adults. Actually, in case of paraplegia flexion, there will be associated mass reflex also, ma'am. Just below the level of lesion, if you scratch, the patient will have sudden piloerection, bowel and bladder incontinence, along with the sweating, will be there, along with flexor spasms. Actually, in paraplegia, extension to flexion indicates that ongoing compression is there in case of spinal cord. Paraplegia extension, only pyramidal tract is involved. It is seen in cerebral causes of paraplegia also. It will be there.
So,
Only pyramidal
yes. So many points you told, but still some clarity is needed. As you have understood, when the child is born, child is in universal flexion.
Yes, ma'am.
At that time, the brain is not myelinated and the higher centers are not myelinated. So how is this child is in universal flexion? The child is in universal flexion as a reflex factor to maintain minimum space inside the uterus. So you have a palm chin and thighs in the trunk.
Yes, ma'am.
Palm chin is the earliest center in the parietal lobe. So at the time of birth, the palm chin center is the only cortical center that is active. So that keeps the palm to the chin. Because of the child is like this. So when you and when the frontal lobe myelinates, frontal lobe will say, now I have come, I am there to make decision. You don't have a reflex posture. So the palm moves away from the chin. When you want, you can keep it. And when you are old and frontotemporal dementia comes, the frontal lobe atrophy, again the palmomandal reflex comes back. Palmomandal reflex is reactivation of the inhibited palm chin center when frontal lobe atrophies. That is why in frontal lobe disease, we get a palmomandal reflex. So who is linking the palm and the chin? It is the palm chin center, which is in the parietal lobe, which is the earliest center in the cortex. Otherwise, child is born in the spinal stage and the child goes through the brainstem stage and then only goes to the cortical stage when the child will stand and walk on its own. So born in the spinal stage, brainstem stage and cortical stage, and only cortical center is the palm chin center. So this palm chin center keeps the palm to the chin. Otherwise, it is only spinal cord because child is in spinal stage. So spinal cord has got short latency flexor reflex afferent. That is called short latency flexor reflex afferent, which are otherwise called SRA. They are intersegmental reflexes in the spinal cord. Between the segments of the spinal cord, they put the body parts in flexion, limbs in flexion, and trunk in extension. So that is short latency flexor reflex afferent. There is no extensor tone at all. Because of that, the child's limb is kept close to the abdomen. Only flexor tone is there. This is maintained by short latency flexor reflex afferent, which are intersegmental reflex in the spinal cord. So the child goes to the brainstem stage, dorsal reticulospinal tract will myelinate. Dorsal reticulospinal tract. That is a tract concerned with the extensor tone. Where is the base of the dorsal reticulospinal tract? It is pons. So dorsal reticulospinal tract base is in the pons and it is connected to the cortex and connected to the spinal cord. So when the dorsal reticulospinal tract, which maintains extensor tone, is myelinating, it will suppress the short latency flexor reflex afferent. So the child will extend the legs slowly. So that is the child foot thrust will be there. Newborn child will do this foot thrust. That means child is slowly going to the brainstem stage. And when the brainstem stage is becoming more complete, child will turn over, child will sit, hold the neck erect. All this is extensor tone. Then you have the, so now the with the extensor tone and the dorsal reticulospinal tract, child can stand also. Because standing is also extension, but child cannot walk. If you want to walk, you need flexion. Dorsal reticulospinal tract has suppressed the flexion, which is mediated by the short latency intersegmental spinal reflex. So if you want to move, your leg has to flex. So how are you going to flex? That is by the corticospinal tract. So that is called long latency flexor reflex operant, or FRAs. So long latency flexion is mediated by the newly developing corticospinal tract. So this corticospinal tract does not suppress extension, and it does nothing. Already the short latency flexor reflex operants are suppressed. So this corticospinal tract and the dorsal reticulospinal tract discuss with the locomotor center. The locomotor center is in the midbrain as well as in the thoracolumbar cord. So it will discuss and tell how do we work together. They make the program. So it will say when you flex your right leg, extend your left leg. When you flex your left leg, extend your right leg so that you can move forward. So that is locomotor coordination. So neither the dorsal reticulospinal tract is suppressed, nor the corticospinal tract is suppressed anymore. Instead, they work together in a coordinated way. That is the time the child starts walking. So flexion happens by the corticospinal tract and extension happens by the dorsal reticulospinal tract. It happens in the coordinated way. So stepping takes place. Now you have a situation where your spinal cord is completely cut. When it is completely cut, neither the dorsal reticulospinal tract which comes from the pons can reach the spinal cord, nor the corticospinal tract which comes from the motor cortex can reach the cord. So neither the flexor reflex afferent nor the extensor afferent is functioning. So now it is preservation of species. The patient is alive. He cannot run and protect himself from an insult. So you become like a worm. You know these worms, when you touch them, they crawl.
Yes.
To protect. That is their defense. So that is by release of the previously inhibited short latency flexor reflex afferent. So which has been inhibited at the neonatal period is disinhibited because it is almost like the final stage of the child. So the short latency flexor reflex afferents are disinhibited. They come back and put the person in flexion like the primitive flexion posture of the worms. So that is their only defense. If a snake is coming to bite, it will crawl. You cannot run. That is paraplegia in flexion. The paraplegia in flexion happens in transection of the cord due to disinhibition of the previously inhibited short latency flexor reflex afferent. So that should be your answer for a paraplegia in flexion. So your patient is not in flexion.
Yes, ma'am.
The patient is not in flexion. Second is paraplegia in extension. So what is paraplegia in extension? Paraplegia in extension is extensor tone is remaining, flexor tone is lost. That's a partial cord injury. So when there is a partial cord injury, as you rightly told, vestibular spinal and reticulospinal tract are very resistant tracts, like warriors. Some warriors fight very bravely till the end. So like that, reticulospinal and reticulospinal tracts are warrior tracts. So they are resistant to insult. So the insult has affected the other tracts. Vestibulospinal, reticulospinal tract is not damaged. So patient is having paraplegia in extension. That extensor tone is maintained. That is paraplegia in extension. Third is flaccid paraplegia. So a pan-cord syndrome can be paraplegia and flexion or moderately retained extensor tones or paraplegia and extension, or you can have a flaccid paraplegia. We get a flaccid paraplegia when there is damage to the cord as well as the root exit zone.
Yes.
The roots, that means complete necrotizing myelitis. So the cord has become toothpaste-like. That is called necrotizing myelitis. It can happen in trauma, some viral infection.
Viral infections.
The spinal cord is supposed to become like toothpaste.
Yes, ma'am.
So necrotizing cord injury, where the cord as well as the root is damaged, you get a flaccid cord. So apparently your patient, from the history, I understand that he has a flaccid cord. From whatever history, examination, I don't know.
Yes,
From
ma'am.
history, I got the feel that it is a flaccid cord. So there is probably a severe necrotizing injury with the cord and root damage. So that is with reference to spinal cord. Second, you told that he is having a dribbling bladder
Yes, ma'am.
and a large bladder.
Mm.
Large dribbling bladder. So when he was catheterized, about 2 liters of urine was drained.
Yes, ma'am.
It's a large dribbling bladder.
Dribbling bladder.
You can have a small dribbling bladder. What is a small dribbling bladder?
Shock bladder is small dribbling bladder.
Very good. It's a shock bladder. Second small dribbling bladder is a transformed bladder.
Okay.
The transformed bladder is you put a patient on catheter for 1 year. And after 1 year, he goes into a chronic contracted bladder. Because we never gave an opportunity for the bladder to expand and store by continuously putting him on catheter. So the bladder goes into contraction, trabeculations, infections. So that is a transformed bladder or a chronic contracted bladder. So one is a shock bladder. Second is a transformed bladder due to chronic catheterization. Whatever may be the cause for whatever may be the type of bladder, you put the patient on chronic catheter for a long time, bladder does not expand at all, it goes into contraction, then he cannot store anything. So it's a small dribbling bladder. Third is a small dribbling bladder, which also happen in sympathetic. So sympathetic is damaged, sympathetic is for storage.
Yes, ma'am.
So if the bladder capacity for the sympathetic alone is about 150 to 200 ml.
200 ml. Yes,
So if the sympathetics alone are damaged, then also poor storage will happen. So after 150 ml or so, the patient will start dribbling. So small dribbling bladder is shock bladder, transformed bladder, and sympathetic bladder. A large dribbling bladder is autonomous bladder.
Yes,
What is autonomous bladder? Autonomous bladder is you have got only the bladder wall receptors.
Yes,
only
ma'am.
the bladder wall receptors are functioning. Nothing else is functioning. That means sympathetic is preserved in the bladder wall. Bladder wall sympathetics is preserved. You have got a beta receptor in the body and alpha receptor in the sphincter. So if the sympathetic is released, beta will relax, alpha will contract, bladder will store to its maximum capacity of
2 to
storage.
2.5 liters.
After that, it will produce reflex and it will produce dribbling.
Yes, ma'am.
So it is only the bladder wall receptors, beta of the body and alpha of the sphincter is functioning. So it will expand, beta will expand to its capacity and alpha will store. And after about 2 to 2.5 liters, the weight of the urine will open the internal sphincter and patient will leak. So apparently your bladder looks like an autonomous bladder.
Yes, ma'am.
So because it is a large leaking bladder. That again means that his roots are also damaged. It is not just the cord, it is the roots. So what is automatic bladder?
Automatic bladder is the sacral.
You said that he has got a thoracic sensory level.
Yes, ma'am.
In that case, if the roots are not damaged, we are expecting an automatic bladder.
Yes, ma'am.
What is an automatic bladder?
Automatic bladder is the roots are preserved, ma'am. Sacral roots are preserved. The higher input is gone from the spinal cord.
So it is more than the bladder wall center.
Yes,
Sacral center is intact.
Yes, ma'am.
Because of the intactness of the sacral center, the patient can store urine up to about 300 to 400 ml. After 300, it is not dependent on the bladder wall receptors. It is dependent on the sacral center. The sacral center can store 400, 450 variable, about 50 ml this side, that side. And then it will ask the higher center. Then it can initiate maturation. Yes, but higher center, it cannot connect. So by hepatic transmission, the impulses come back and empty. So automatic bladder is about 400 ml.
Yes,
Sacral center is intact. So it will not obey the bladder wall receptor alone and keep on expanding like the autonomic bladder. At 400 ml, it will try to send impulse upwards. It will not go. So the ascending impulses come back by a capsis and spontaneously initiate maturation. So automatic bladder, patient may have partial or complete loss of sensation depending on complete transduction or partial transduction. It will store about 400 ml.
yes,
It will not dribble, at least initially, until infections and all come, it will not dribble. It will empty large amount at shorter intervals. It will empty some 300 ml, not drops like autonomous bladder. It will empty about 300 ml. Patient will not be able to stop maturation. Patient cannot initiate maturation. Patient cannot end maturation also. That is why it is called automatic. Automatically, it will empty when the bladder is having about 400 ml, and it will stop once the stimuli to the sacral center is gone. So at about 150 ml, stimuli to the sacral center will not be there. So it will become the residual urine.
Dysenergia will be
So
there.
it will have a large residual urine. And this residual urine can produce sometimes post-void dribbling.
Post-mortem dribbling.
So he can have about 200 to 300 ml emptied. And after that, he might dribble because of the larger residual urine. And these people have a hypertonic bladder, and they can have reflux and damage the kidney. So that is automatic bladder. What are all the other types of bladders you want to tell?
Yes, ma'am. Frontal uninhibited bladder will be there, ma'am, where bladder function is fine, but he doesn't have any social inhibition. He will pass urine wherever he wants, and he doesn't have guilt also.
Yes.
And one more frontal
There is
bladder.
no reflex, there is no infection, no dribbling. He completely empties in socially inappropriate
place.
Then
if paracentral lobule is involved, patient will have the sensation, and the patient can initiate the maturation, but he will tell, I won't pass the urine.
It is like a frontal licotomized
Yes, ma'am.
He is indifferent.
Indifferent.
Indifferent to bladder sensation.
Yes, ma'am. The other type is automatic and autonomous. The other one is sensory denervated bladder, ma'am. In tabes dorsalis or pseudotabes, well, sensations are not there, but he can initiate the micturition. To those patients, we have to tell, for periodically, you go and micturate. You won't have sensations. You itself go and micturate like that. We have to train the patients, ma'am. That is sensory denervated bladder.
Recently, we don't, previously, we used to tell like that because what we need is a social continence. Okay. But now we know that even painless storage will produce reflex and renal damage. Okay. So all these element human patients are taught to do self-catheterization. Even though he can empty good amount, he may still have the dysenergia. Okay. So that part you have to be cautious. They can empty if they can voluntarily initiate maturation. That part is correct.
Yes,
but they still have residual urine. Okay, next. So the renal damage will need to be emptied by removing the residual urine.
Okay. Next, motor denervated bladder, ma'am, which is very painful bladder. They cannot initiate the maturation, but they have the pain and the full sensations will be there.
Good. That happens in polio,
all this
short period, very short. By God's grace, it's a self-limited bladder. Next. Partial bladders.
Partial cord bladders will be there.
Hesitancy based on inhibitory fiber or inhibitory fiber is involved. Next is the autonomous bladder, like your patient's bladder. Last is the destrosa external sphincter dysenergy.
That is due to lymphogranuloma venerum infection.
Pudendal nerve injury.
Okay.
Whatever causes pudendal nerve injury. Yes, so only the external sphincter is refusing to open.
Yes, ma'am.
All other parts of bladder function will be normal. Patient will sense it, everything. He will try to initiate. So if you have a history of some pelvic injury or previous inflammatory disease of the perianal region where the pudendal nerve might have been trapped, that can be tested by doing a pudendal block test to give. Yes. And if the person empties, then you can do a pudendal neurectomy or external sphincter resection. That is all is needed for such patients. So this is an autonomous bladder. which is the worst bladder stuff.
Yes,
So
ma'am.
any other symptom here? You said yes, constipation.
Yes, ma'am. He has
And
constipation.
with reference to bowel, it is usually constipation, and we have we will not be able to type it because whether it is LMN or EMN, both present with the constipation only. So that part is okay. Next, you said that he is having dry skin
Yes, ma'am.
and he has decreased sweating. So there is also autonomic involvement.
Dysfunction will
In
be.
these type of patients, sometimes you find compensatory hyperhidrosis in the uninjured
Other
area.
areas.
Does he experience that?
Yes, ma'am. He has excessive sweating in the face and upper part of the body. He has very severe sweating.
So that is a compensatory hypersweating
Yes.
for thermoregulatory purpose.
Hmm.
So that is for thermoregulatory purpose. But when you really do the trunk heating experiments and all, this thermoregulatory sweating will be absent below the lesion, and thermoregulatory sweating will be exaggerated above the lesion. So that point also you can tell. My patient has excessive sweating. That means the thermoregulatory sweating is increased above the level of pathology and decreased below the level of pathology. So it's a pan-cord syndrome with an autonomous bladder with element. And apparently from the history, you said that he is having wasting. So that means that wasting might be an element. So it's a cord and root
involvement.
both involved. So that's what. So at this point, for the sake of smaller, younger colleagues, your first year students or undergraduates who are maybe there, I don't know.
Yes,
You just tell me the points to differentiate UMN disease from LM. It's a very simple question. I know you are very well read, very good, but just want for the sake of younger colleagues, you can tell how to differentiate UMN disease from LM. Generally, overall.
Yes, ma'am. Overall, UMN disease will have fine skilled discrete movements will be lost, ma'am, in case of UMN lesion. And they'll be associated spasticity, hypertonia will be there, which is velocity dependent, class wise spasticity will be there. And UMN is a movement paralysis where kinetic melody is lost. And LMN is always, and UMN will have disuse atrophy usually. And LMN is proximal weakness will be usually in the will be most, and the patient will have hypotonia and hyporeflexia, and the wasting will be there, and fasciculations will be there. All this, and the lesion is usually from the anterior honsal to anterior honsal plexus, anterior honsal roots, plexus, peripheral nerve, and NMG and muscles, ma'am. Above the anterior honsal usually causes a UMN type of paralysis.
Some key points which you left off. You typically told that it is movement paralysis.
Yes, ma'am.
It is not muscle paralysis. That is true. Because muscles are not paralyzed, there is voluntary reflex dissociation. So voluntary movements, you tell the patient who is a typing person to work on the typewriter, he cannot. But you try to elicit a finger flexion reflex. That movement will be very much exaggerated. So voluntary movements are impaired, reflex movements are increased.
Okay.
Because there is no muscle paralysis. That is UMN. Whereas in LMN, both voluntary movements and reflex movements are lost. Because there is muscle paralysis. UMN, certain movements, the fine movements, the melody of movement is lost, as you rightly told. Because of that, voluntary movements are lost, reflex movements. Second thing with reflex is superficial versus deep. In LMN, both superficial and deep reflexes are lost. Whereas in UMN, superficial reflexes are lost, deep reflexes are exaggerated. Very key point. Then if it is in that zone, upgoing plantar. Whereas LMN, it is not there. Then LMN, there is diffuse wasting. Whereas in UMN, over a period of time, disuse atrophy, which is otherwise called hypoplasia. It is not a focal thinning or increased grooving or something like that. The whole limb appears diffusely small. That is called disuse atrophy, which happens over a period of time. So these are the points. LMN depends on the territory, not that it is proximal or distal. Depending on whichever nerve or root is damaged, there is loss of power. the fine movements are lost early and coarse movements are lost late. So that is the point. Good. That is for the sake of, I thought just revise it for the younger police. So apparently from your history, our patient has got a dynamic injury to the brain, brief with no parenchymal insult, and has got a penetrating injury to the cord. So the two things. And what was the injury to the cord? Apparently he was operated. So we think that probably he had a vertebral injury, but he had a complete cord lesion from the day of trauma, from which he never recovered. So most probably he had a neurotomesis of the cord with the necrotizing change involving the roots and the root entry zone, resulting in LME. So it is complete diagnosis if you want to tell. It's a dynamic brain injury and a compressive cord injury involving both vertebra and the spinal cord. And in the spinal cord, it is a pan cord, probably neurotomesis with also involvement of the roots. That becomes the diagnosis. So what all ways the roots get involved in a cord injury? One thing, it may be a complete crush of the cord below D4, a long segment cord crush injury. That is one possibility. Second possibility is transection at one level and below that bleed, spinal bleed. Due to the trauma, the blood comes, produces arachnoiditis and damages the roots. So both are possible, we do not know. Because he did not, I don't know whether he had multiple vertebral injury. If he had multiple vertebral injury, it can point to a multiple segments of cord crush injury throughout below the thoracic cord, or he could have had a cord injury at the highest level that you are having now, plus arachnoiditis due to the traumatic subarachnoid hemorrhage. Traumatic spinal subarachnoid hemorrhage, not cerebral. Traumatic spinal subarachnoid hemorrhage leading to aseptic arachnoiditis, and that produces the root damage. So this will be the history diagnosis of your patient.
Yes,
this is straightforward case, just a discussion on various ways of the cord.
Yes,
Then you know, you have anterior cord, posterior cord, hemicord, pan cord, central cord.
yes,
All things I'm sure you know, and how to calculate the relationship between the vertebra and the segment.
Yes, ma'am.
Those things you should know. Okay. You have written about Adam-Key artery.
Yes, ma'am.
Why did you think of that?
Ma'am, yes, ma'am. This artery of Adam case is the biggest radicular artery, which is a branch of descending abdominal aorta from the left side. It will supply from T9 to L2 segment. Unlike the anterospinal artery and postspinal, which supplies half of the cord, like 2/3, it supplies whole the cord. No, ma'am. Artery of Adam case will supplies whole the cord. So
two levels you get pan cord in vascular. It is arteria cervicalis magna and Adam-Key artery in the lumbar region. You can consider that. But probably he underwent surgery and all those things. So it must have been a direct cord injury than a ischemic insult. Adam-Key artery, you think when there is an aortic dissection. Aortic dissection where the mouth of the Adam-Key artery get uploaded. That is one situation. Otherwise, some kind of systemic vasculitis, Tokai-arthritis, which is arterial inflammatory disorder. They can upload the Adam-Key artery. Otherwise, acute spinal cord condition due to Adam-Key is dissection. So we don't know traumatic dissection happened or not. So that possibility is a good possibility you can keep for this level. Great. Next.
Next, ma'am.
Multiple disc, I will not consider. You have written multiple disc as another possibility. Multiple disc, because we are not having the history of multiple root pains and significant cord. Then you have say multiple central disc herniation, which is more theory. Then clinically it's difficult to explain when there is so much of damage to explain it as a disc lesion in an unusual site. Even in a dynamic spine injury, the disc is located at C4, C5 or L1 level. But this is a thoracic level where it is theoretical possibility So I will not consider that. Okay.
Ma'am, ligament buckling into the spinal canal, ligament flavum buckling into the spinal canal. What type of injury we can expect, ma'am? What will happen exactly?
No, this usually presents like wasted arm syndrome, anterior console leg, because you demonstrate ligament of flavum buckling, and it can present like a compressive myelopathy involving posterior column and femoral tract. But but unusual manifestation is MND like presentation, fly arm syndrome. And then when you imagine, when you investigate, you find that there is a thickening of the ligament. Yes, that's a treatable. Wasted arm syndromes. Monomelic atrophy, single arm atrophy, where the ligaments buckle and they produce a anterior console involvement by involvement of the sulcocommissural artery compression mechanism postulated. The decompression is believed to prevent progression of that motor neuron disease. But not much success has been demonstrated. Young people, they come with wasted arm because we want to give some treatment to MND patients. So this is one offered, and people have demonstrated ligament thickening and they have decompressed. I have seen large series, even though in the scores, they may say that by motor score, the score improved by 0.51. That's okay for a paper, but for a patient, significant improvements are very less. So that is buckling of the ligament reticulation, which is happening. Suppose it presents like a myelopathy, then the prognosis is very good, like a compression on the posterior column or corticospinal tract. But when it presents MND like, we have not seen good prognosis.
Okay, thank you. Yes, ma'am. On general examination, patient was conscious, oriented, cooperative, stable at rest, normally built and nourished, right-handed individual, afebrile, no pallor, icterus, clubbing, cyanosis, lymphadenopathy, and pedal edema. No neurocutaneous markers, no peripheral nerve thickening. Tattoos were present in both arms. Ulcer was present on right gluteal region. Surgical scar was present over T12 vertebra.
Does he have any gibbous there?
No, ma'am. No. Exam. Yes. Vitals data, pulse rate 90 per minute, regular in rhythm, normal volume, no specific character, no vessel wall thickening, no radial and radiofemoral delay. BP was 120/80, measured in right upper limb in supine position, and 110/70 in sitting posture. Respirator is 14 per minute, regular abdominothoracic type. Temperature febrile.
So why is the sitting pressure little less? Yes. Normally, what do we expect, sitting and standing?
Yes, ma'am. Sitting normally, I couldn't understand.
Normally,
yes,
you expect the BP to go up.
Yes, ma'am. Yes, ma'am.
Because of the baroreceptors in the limbs become sensitive, and the patient is sitting, so more pressure is needed to pump blood to the brain.
Yes, ma'am.
When you are lying, less pressure is sufficient. When you are sitting, it should be more. But when the baroreceptors have failed,
yes, ma'am,
this increase in the blood pressure, which happens with erect posture, for the purpose of pumping blood into the brain, does not happen. That because the lower body autonomic dysfunction, baroreceptors are not sensing, so he is having a posture of hypotension in the sitting position. He cannot be tested in the standing.
Yes,
I think so. But if you support and stand, it will be much worse. Because of the autonomic failure.
Dysfunction. And his heart
baroreceptor dysfunction.
Yes, ma'am. His heart rate is also always above 95, ma'am. It's look like resting tachycardia. Even at rest, it's always 95. So like autonomic dysfunction only.
Okay, orthostatic tachycardia and hypotension.
Hypotension, both are there.
Okay, next.
Next, higher mental functions. He's conscious, well-oriented to time, place, and person. Memory, immediate, recent, and remote is intact. Speech and language is normal. No emotional liability, no delusion, hallucinations. MMS score is 28, 30. 28.
Okay.
Cranial nerves are...
Temperature in the affected body part, is it low?
Temperature...
In this case, that is more relevant. Then the core body temperature.
Yes, ma'am.
The affected area, thermoregulatory failure, that's an autonomic dysfunction. Like you have demonstrated the increased heart rate and decreased BP in the sitting posture. The affected body part temperature, if you record skin temperature, may be lower. That will indicate thermoregulatory failure as another parameter of autonomic function.
Yes, ma'am.
How do you check sweating? You have got at the bedside. Of course, you have got the laboratory quantitative sweat test.
Yes, ma'am.
That's the laboratory. You can measure the test secretion of sweat by electrical stimulation, by a mechanism called iontophoresis. You do that and find out how much sweat is produced. Is it there or not at all there, or is it reduced? That is called Coursot test or quantitative sweat test. That in the laboratory, it is not there in all the small ordinary laboratories. It will not be there.
Yes,
At the bedside, what we do is you can do starch iodide powder. You see, starch iodide powder is not easily available, so we generally use betadine. Betadine is iodine. No? You can smear the patient's body with betadine. And starch powder, which you use to starch your clothes. We use starch powder to starch cotton sarees.
Yes, ma'am. After
Smear betadine and sprinkle this starch powder and give them whole body and give them a hot cup of tea and 1 tablet of aspirin. That will normally produce sweating. Aspirin with hot cup of coffee produces sweating, and you have smeared this. So whichever body part there is no sweating, the starch powder does not turn blue. Starch iodide powder,
yes, ma'am.
If there is sweating, it will turn blue. That way you can demonstrate, take a picture of the patient after that.
Yes,
and you can say these much areas are not sweating. Otherwise, there is another test called quinosarin powder. Starch iodide is very easy. All of us have betadine in our wards and starch powder in your homes. You can do that. No? Next is the quinosarin powder. That will turn pink. Quinosarin powder is not easily available. Sprinkle quinosarin powder and give the same thing, coffee and aspirin. And it will turn pink in areas where it is sweating. In areas where there is no sweat, it remains like that.
Yes, ma'am.
These are various autonomic functions. You have said that he is dry, he has bladder, he has erectile dysfunction. All these are autonomic dysfunction, and you have demonstrated postural hypotension, resting tachycardia. In addition, simply 2 more things you can demonstrate. Because autonomic always we will miss it out. So
Yes,
many are detected: bladder, bowel, erectile function, sweating, dry skin, postural hypotension, resting tachycardia.
And
Then you
B2
can check the temperature and say thermoregulatory failure is there.
Yes,
and
ma'am.
I will do starch iodide. Why you will do starch iodide? If the patient goes to a very cold place, he might die of severe cold. Or if he goes to a very hot place, he will die of heat because he has no thermoregulation. So I will want to check if it is more than 20 to 30% of thermoregulatory failure. You will be very careful. You will have to use cooling or warming blankets if you take him to places of extreme climatic conditions. If it is less than 20%, body mechanisms will adopt. If it is more than that, it will cause harm to the patient. So that way you can assess. He is a young man, he might want to tour and travel and all those things. Okay,
Yes,
that make your autonomic function little more complete.
Ma'am, some of the tests I just have read somewhere that if we keep one hand in cold water, the other hand.
That is not for the spinal cord.
Okay, ma'am.
Fan autonomic failure.
Okay.
So you can do the auto regulation, induced blood pressure and heart rate changes.
Yes,
normal, you have got a sinus arrhythmia, and you can have Mendel arithmetic, and you can do your pressure on the holding on to the examiner, or you can hold on to the BP cuff and then check the heart rate, and you can do the Valsalva maneuver.
Valsalva, yes.
It's all called fan autonomic.
Okay.
Not for the cord alone.
Okay. And MMSE score is 28, ma'am. And cranial nerves examination is within normal limits. Coming to motor examination, patient is in supine position, Attitude, patient is in supine position. Bilateral upper limbs are on the side of the body, and bilateral lower limbs, legs are rested on the bed, ma'am. Wasting noted over both the lower limbs, but there are no fasciculations. Yes, ma'am.
No fasciculations. Okay.
No fasciculations, yes, ma'am. Bulk of the lower limbs bulk is reduced, ma'am, 35 and 35 centimeters. Upper limb, when compared to upper limb 31, lower limb bulk is completely reduced 35. I mean, both are equal almost. And tone is lower limbs hypotonia is there, ma'am. And upper limb power is completely fine, 5/5. Lower limbs, when it's hip flexion, extension, adduction, 0/5, but abduction alone 2/5, ma'am. Everything else is 0/5. Knee flexion, extension, ankle dorsiflexion, plantar flexion, everything is this thing. That's why we took the video of that abduction video also, ma'am. Only abduction alone he is able to do, at least with the 2/5. How can it be possible, ma'am?
Abduction is L5.
L5, ma'am. Gluteus minimus and medius.
Maybe that segment is relatively preserved. And this we thought that the cord and root involvement, flaccid,
yes, ma'am.
Cord crush injury cannot be due to the trauma at that highest level where the repair was done. So at that level alone cannot produce a fan cord and root crush. We
yes,
thought that either the spinal cord is crushed in a long segment directly or by an arachnoiditis. Both can be differentially involved. So it is either the cord crush spared that L5 segment, relatively spared that L5 segment, or the arachnoiditis relatively spared that L5. It's also affected. It's only partially better.
Yes, ma'am.
So that segment, that again indicates the same etiology only. Fan cord crush or arachnoiditis with partial sparing of that segment L5.
Okay.
Like that only it is playing.
Yes, ma'am. And coming to superficial reflexes, ma'am. Corneal, conjunctival, Georgette, everything is present. Abdominal reflexes, upper and middle present, ma'am. Lower reflex is absent. Lower abdominal reflex is absent. And cremastic is absent. Bulbocavernous is absent. And anal sphincter is lax. Anal reflex is absent. And plantar is no response, ma'am.
So that all indicate element goes with autonomous bladder and the element involved.
Element, yes, ma'am. And coming to deep tendon reflexes, upper limb reflexes are fine. And lower limb.
Yeah, Beaver's sign?
Beaver's one was negative, ma'am.
Means you said the upper is present, lower is absent.
Abdominal lower reflex alone, superficial reflex is absent, ma'am. But Beaver's ways, it's fine only, ma'am. Coming to sensations, ma'am. Group touch, pain and temperature are normal till T10, and there is decreased from T10 to T12. Below T12, completely absent, ma'am. And vibration also until T12 he's able to feel, and after that he is not able to feel them down. Joint position from hip joint he is not able to feel everything down, and saddle anesthesia and perianal sensations, everything is lost. Cortical sensation was not checked as
primary. Saddle anesthesia because you have total loss below T12. No, that includes the saddle anesthesia. You have to mention saddle anesthesia if it is corner alone. That it becomes relevant. Here it is below that T12 itself it is locked. Then specifically now you don't have to tell like that.
Sure. And the cortical sensation was not checked because everything is lost, ma'am. All primary modalities is lost. Coming to cerebellum, no cerebellar signs are negative only, ma'am. And autonomic nervous system, postal hypotension is present, sorry, ma'am, and abdominal sweating is present, resting tachycardia is present, gait couldn't be assessed. Meningeal signs are negative. Spinal
bowel also autonomic.
Oh, yes, ma'am. Bowel and bladder is
dry skin.
Dry skin and sweating, bowel and bladder involvement, erectile dysfunction, everything is involved.
All those things you can put under autonomic.
Okay, yes, ma'am. Yes. And other system examination is within normal limits. Summarizing the examination, it is a traumatic acute flaccid paraplegia, which is associated with wasting for subsequent years. Band-like sensation is there at the level of T12. Complete sensory loss below T12, and bowel and bladder involvement. absent patellar and ankle reflexes, absent cremastic, bulbar cavernous, and lower abdominal reflexes.
So what are all the bad points in this patient? What are all the good points in this patient? The good point is his brain is intact, his upper limbs are intact.
Yes, ma'am.
The bad point is, apart from the UMN level transverse cord at the D10, his LMN is also gone. So the main switch is also gone, bulb is also gone. So he has no chance of recovery of power clinically in this patient. So that's a bad point. So now what we are going to use, if you have to, as you have rightly done, he has bladder, should be protected, being a young man, to prevent reflux, prevent infection. The best way to do intermittent catheterization. That you have already taught him.
Yes.
And bowel.
Manual evacuation, ma'am, daily on his own.
You can teaching this some kind of bulk laxatives.
Okay.
Bulk laxatives will mechanically empty.
Yes,
or he can even try this proctoclis or something like that instead of manual evacuation. That is not correct training for him. Bulk laxatives, not the irritant laxatives. The bulk laxatives might help. Otherwise, he can use a small enemas.
Okay.
That he can use. Next, for ambulation, you have got gaiters. There is something called gaiter because the upper limb is all right. So his body can be fitted into the gaiter, which will keep the knee and the straight angle dorsiflex, and it will be fitted into the trunk. So he can walk. That is called gaiter, external gaiters. They are rehabilitatory tools available. That is why I said the upper limb is preserved. That is very good for him. Wheelchair he will use only in special situations. Because once he sits in the wheelchair, his leg will completely go. It's only 35. Wheelchair is a death sentence for wasting. So completely it will become wasted. They will find it comfortable. So they will stop attempting any other methods. Whereas gaiter-based walking is, they have to strain a little. So otherwise, if he had a hypertonic weakness,
then
you could have given him some more training. You can give mechanically the stepping training and all. That is called treadmill training. Patients are suspended from above and made to run on the treadmill. So they develop the locomotor center in the midbrain and learn to do the cycling movements. So they may drag and walk, but it is a flaccid paraplegia. So nothing else is going to work for him. So you'll have to give me a gaiter attached to the trunk and give wheelchair only when he goes to airport or some places like that.
Yes, ma'am.
So bladder, bowel and gaiter-based walking. Okay. Very unfortunate patient. That bed sore should be treated properly. That should not produce infection cellulitis. And you should tell him to not to be resting all the time. He might develop DVT and pulmonary embolism. All those things.
Yes, ma'am.
That's all. Nothing else we can. Any questions you can ask? Thank you very much. Straightforward case, but you did very well. Nice. Nice presentation. Good.
Nice, ma'am. Ma'am, traumatic myeloradiculopathy producing conus and injury to the artery of Adam Kivis. This one I can remove. Traumatic myeloradiculopathy. That is my final diagnosis. That is ma'am. And I have some MRI pictures, ma'am. This one.
What do you see in the spine? It's post-operative picture.
Yes, ma'am. It's post-operative, ma'am. Before surgery, we didn't have, ma'am. This one, T11, T12, and L1 screw fixation was there, ma'am.
Cord, you are not able to see at that level. If you had the pre-operative picture, yes, we can see whether the cord is cut into two. Now, because the screws are overriding, at that segment, cord is not clearly visible.
Yes, ma'am.
Clearly, I am not able to see.
I have axial section also, ma'am. I will show that. Yeah, the screws actually not that clear.
Artifacts.
Yes, ma'am. It's artifact.
Apparently, I'm not able to demonstrate any signal changes or anything in these pictures.
Okay, ma'am.
Originally, you might have seen some hematoma or signal changes. Very much possible because of the post-operative changes, I'm not able to see through the cord. Vertebra and the screws we are seeing. Roots
Yes,
are seen.
ma'am.
Distinctly roots are seen below.
Okay, ma'am.
Kidney is all right. Immediate post-operative kidney is all right. Okay.
Ma'am, can I ask one question, ma'am? Ma'am, can it in rare cases, spinal shock, can it be permanent? Even in
No.
rare cases? No,
No.
it's not at all possible.
We use the term spinal shock when the damage to the cord is incomplete, but functional failure is complete.
Okay.
The term spinal shock is only applied when there is an incomplete cord injury and the functional deficit at a particular point of time is complete.
Yes,
So
ma'am.
mismatch between the degree of cord injury and degree of neurological deficit. Then only you use the term shock. Otherwise, you don't use the term shock.
Okay, ma'am. Yes, ma'am.
Any other question? Because
Okay.
I am retired person.
Yes,
So
ma'am.
thanks for giving me an opportunity to meet young people like you. You did very well. Thank you very much.
Thank you so much, ma'am. So I was so glad that I finally presented a case to you. Thank you so much, ma'am. Thank you, Hanifah sir and Tumanadam sir, Senthil sir. Thank you so much, sir, for this.
Thanks a lot, ma'am.
It
We are
was
quite
so-
a lot of old people following you very close.
Thank you so much, sir.
We have learned a lot from you, not only the young people, also retired people and going to retired people. Thanks a lot, ma'am.
Thank you,
Yes,
madam.
ma'am. Thank you so much, ma'am. Thank you so much.
Close, huh? Close? Should we
Divya,
close?
ma'am, only 1 minute.
Yes.
Can you hear me?
Yes, I can
Yeah,
hear you.
very good presentation, Dr. Divya. Congratulations.
Thank you,
Okay,
sir.
because of your well-prepared presentation, we could learn a lot. Madam also went on like elaborating everything, so we could learn a lot. And I should thankful to Professor Mohamed Hanifah sir for preparing such a wonderful student and a wonderful presentation. Thank you, Mohamed Hanifah sir, for being
Thank
with
you,
us today.
sir. Thank you. Thank you
Any
to the White Army.
your side, please? Any concluding remarks from your side about the case and also about the presenter?
Yeah, we had a lot of doubts in the department, particularly the abduction at the hip joint. So we are wondering why that alone has to be spared when every other movement has been zero power. That is one. And one of the strongest thing that came to mind is, even though there is a proper level there, like a spinal cord level, as evidenced by the sensory level at about T12 and 11, yeah, in that level. But is it because of necrotizing myelitis that the patient has had almost all the elements sort of
Yes.
presentation? And that very well madam has clarified. So we were quite convinced about the pathology that is being involved.
Thank you, sir.
Madam has
Thank
been
you.
the backbone of White Army, and we have got so many followers just because of Chandra madam's classes, and she's been a source of continuous inspiration and motivation for all of us to do more and better in our field. Thank you once again, madam, for inspiring us. Thank you. And once again, I request Dr. Dhivya to present many more cases like this. And it's a wonderful opportunity to learn from madam as well as to teach your juniors. See, nobody will get such an opportunity. Whereas you learn simultaneously, you learn as well as you teach others.
Yes,
see, thousands of students watch your video and learn from you. Okay, so keep up the spirit. Okay, and you have got such a good mentor in your college as a professor. Madam, you will, I will not believe. Professor himself messaged me asking for a chance for his PG to present this case. I really overwhelmed. It's a great honor I felt. Professor is requesting for his student to present a case. I never seen of such high stature. I never seen. So may like Mohamed, Hanifah sir also teach us more and more, so that we all can continue your legacy in future. Thank you so much. We had a wonderful study session. I thank all the active participants also. And
opportunity. Thank you. And
thank you, sir.
teachers
Thank you,
also.
madam. We are humbled actually by your praise.
Thank you.
Yes.
it's a fact, sir. No
Thank you.
praise in that. It's just a fact, I told. No
Thanks, sir.
praise,
Thanks a
no
lot.
exaggeration.
Thanks, sir.
Thank you, sir. We are really grateful and
Thank you.
thankful to your mentors like you, who are really selfless and dedicated yourself for teaching and also bringing up the younger generation. We hardly see such passionate and dedicated teachers like you. So the White Army is just because of dedicated mentors like you. Whatever we are today is because of the teachers like you. Thank you so much.
Thank you.
Thank you, sir. Thank you very
Thank you
much.
so much, sir.
Thank
Thank
you.
you so much.
Thank you.